So I will talk a bit about randomized or interventional trials, and I will talk about randomized controlled trials. And I will try to make it a bit practical. As Ricardo said, I'm a physiotherapist by background. I'm a senior researcher working at Diakonhjemmet Hospital, and I'm the project manager of 7 studies. 4 of them are randomized controlled trials, so it's a lot to do. I'm not going to say that never do a randomized controlled trial, but it's really important that you think about it up front, or else we will end up, as Richard mentioned, that it's research waste. We have conducted it in a bad way. We can't rely on the results, so we could just not have done it. That would be better, because it comes out bad in a systematic review or something. So I'm going to look at the blue one here. And just to follow up on Loretta, it's always the question that guides us to the design. We do not choose the design first and then we try to make a question. We make the question, and then we have to figure out which design do we have to use to answer this question. The only thing that I do, I never do a qualitative research question, because I'm really bad at that one. So that's the only thing that I choose not to formulate, but it is the question that guides us to what design. So there are a lot of potential biases, and I just mentioned some of them. So there are errors that is associated with healthcare research. So we have the selection bias. Bias is that it's kind of derived from the truth. It's a systematic error, and that is problematic with systematic errors, because we can't do anything about them. If we have random errors, they kind of go in both directions. We just get a wider or more deviation in our results. But if we have a systematic bias, then we have a problem. And I just like to mention some of all my mistakes. I've done a lot of mistakes, but I've learned a lot from them. And I think that's nice. It's not so nice when you're defending it, but it's nice because I will never do them again. And it's the small things. I just, for my PhD, I was collecting data. I had an assistant to help me, and we were measuring weight. And I thought, okay, we're 2 persons, I just buy 2 weights, so we can just do it easier. We did that, and after the study, I just, it's 2 kilograms difference in these 2 weights, and we did not know which weight the patient went on. So it's a minor detail, but it's quite important. So you have to think about everything, and you have to think about it up front. And that's the difficult part, because when I was pregnant, I went to the nurse, and I asked, and she asked, do you have any questions? I said, it's the first time, I don't know what to ask about. And if it's the first time you do a randomized controlled trial, it's not easy to know what to think about. But you have to think about these things, and that's why we have these guidelines, and we have much things that you could look into just to help with trying to lower the bias in your study. So selection bias, we always have that because it's voluntarily to join into a study. So we will most often get somebody who is interested in the topic that we have. It's difficult to come by that, but we have to try to make it as good as possible. We have the confounding. That is also because there might be other things that is the reason for our results. You know, there are done many studies on cancer, and they find that in our daily press in Norway, they want the news, so they say that drinking can cause cancer. But do you think it's something that's confounding those results? You know anything that could confound these results? Perhaps if you drink a lot, then you smoke a lot, yeah? Or you're a party smoker, so you smoke and you drink. So often we have a confounding variable that we need to take care of. And also the chance, the random errors, we need to try to make them as small as possible. And then the good thing is that doing a randomized control trial, we can at least take care of some of these errors. Just my question, I think, because I think we have talked about this. So in a non-pharmacological randomized control trial, what would you think is a common problem in this? And bear in mind that I'm a physiotherapist, so I'm kind of using myself as example here. What do you think is a problem? Yeah, I think all of them, yes. But but the difficult part in physiotherapy is the blinding, because we can never blind the patient, and we can't blind the therapist, because the patient will know that he or she is training. The therapist will know that he or she is training the patient. So blinding is difficult, but all the others are also difficult. They are. So although it's an old reference, I think that this is a nice overview of features of a well-designed RCT. We need a proper or appropriate study sample, so we need to calculate the power. We need randomization, because that is an important thing about randomized controlled trials. We need it to be prospective. That will, if we do retrospective, it's already we have some errors or bias to that trial. I know there are now doing more registry RCTs, but that's on registry data. Both groups has to be treated equally, except for the intervention being tested. And that's also a really difficult part in non-pharmacological research. And that is, or at least in physiotherapy, if we think about exercise or something, there has to be a therapist involved in the interventional group. And this person is not involved in the control group if the control group is usual care or no intervention. And the problem is then the impact or the effect of that person. Some colleagues of mine did an exercise trial on osteoarthritis, and they were ladies, mid-50, really nice looking ladies. And most of the participants were a bit older. There were a few men there, and they came with wine to these physiotherapists. And you know that it's not only the exercise that perhaps gave the results, because they were really enthusiastic women doing the trial. So the attention might also be an important bit. And it's not always easy to make that equal in both groups. And as mentioned, the investigator should be blinded, but that's really difficult. So at least the statistician, perhaps if we can manage the one collecting the data, if there is a possibility that the collecting the data might cause some biases, we perhaps have to have a blinded outcome, or a blinded person blinded for the outcome measure. But it's something that you should think about, because if if you add up this, you need a lot of people. You need somebody who's blinded to the outcome, and you need somebody else to do the intervention, and you need a statistician, and so on. So you need a lot of people. That cost money. It's difficult to do because, or in Norway we get funding for one PhD, and we don't get additional funding for a person or I don't know what you call it, but somebody helping. You don't get additional funding, so you have to seek for that as well. So it's difficult to do a really well-designed RCT. You should do intention to treat analysis. That is that you analyze those who were randomized to that group, and you analyze in that group that they should be. You also should do per protocol, that is the people who have done the exercise that you planned. You should keep only those in the groups. I think that we will talk more about this in another lecture. And now it's highly important that you predefine your hypothesis and statistical analysis. This has become more and more important, and now we have to publish protocol. We have to publish a statistical analysis plan, and this should be done in forehand. So it's a lot to think about before you start a trial. You should really plan it well. And the last part, it's very good because you shouldn't, we call it fish for data. I don't know what you call it, but you shouldn't be out fishing trying to find something that's significant. So if you plan up front, then you will not be fishing for these results. So I'll talk a bit about, this clock is a bit wrong because in Norwegian time. I will talk a bit about some common RCT designs. And there are a lot of different designs, so I'll just talk a bit about some of them. And the simplest one, although it's not simple to do, but it's the simplest design, it's a parallel design. So one participant is randomized or placed in one group or in one arm and will follow that arm all through the study. So this is the simplest one. I will just show, this is a study that we have conducted at Diakonhjemmet, one of my PhD students. And it's, we call it the EXEHAR trial. It's a high intensity exercise for people with inflammatory joint diseases. So they're randomized to either getting high intensity exercise with a physiotherapist in primary care, or usual care, which is the control group, which is just advice on being physically active, and then they can do whatever they have usually been doing. So the first thing is that we have 4 different physiotherapists out in primary care, which do the intervention. And then the PhD candidate, she has done the outcome, measuring of the outcome, so she's blinded. So I had to call all the patients to say which group they ended up in. So then it's 6 persons already. And sometimes the patients called the PhD student, and then she understood that, oh, you have to be in the intervention group. So then she was unblinded, and then we had to have another person doing this measurement of VO2 max. So then it was 7 people altogether in this trial. It's only 60 persons, so it's kind of small. It's not that large sample, but it was what was calculated. But still, there are a lot of people involved in conducting this trial just to try to make it the best that we can. And we have done, at the measurement time points, the PhD candidate has tried to guess. So before she started to do the measure the outcome, she tried to guess which group, and she's wrong, or it's just by chance. She have not managed to guess very many correctly. But then we had to tell them, do not wear, because everybody in the intervention group got a polar watch. So do not wear that. So you have to tell the patient, you have to be aware of things that can be, that you can try to guess which group they are in. As mentioned, when you plan a study, as you see there is oops, that was the wrong way. There is a lot of work, there is a lot of planning behind this relatively small trial, which we have to think about up front. Richard mentioned the risk of bias, Cochrane risk of bias. That's a very good thing to look about. He also mentioned this equator network where we have the guidelines for how to report. Although that's far ahead, it's a long time before you can report your data, it's really important to think about that when you plan it. So go through all the different parts. This is just the title and method, and there are a lot of the results and everything. Just go through it so that you know that you have everything in place, or else the study, although you try to make it as good as possible, you're ending up in kind of a research waste because the study will have high risk of bias if it's included in systematic review. And then we can't rely that much on the results. So I will also mention there are different ways of analyzing or conducting a randomized controlled trial. So we can have a superiority trial, we can have a non-inferiority trial, or an equivalency trial. Well, I'm sorry. Yeah, just equal. For the superiority trial, that's the most common trial. Then we think that, or we want to assess if treatment A is better than treatment B, or placebo, or a control group in some way. I've put down here, if you see the line in the middle, that's no difference between the two groups. And the box, that's the average difference between the two groups, and then you have the confidence interval. You with me on that? Yeah. So you see that if it's, I'm sorry, I'm out of the camera perhaps, but if it's here, it's not crossing the line. If the confidence interval is crossing this line of no difference, then it's not, we cannot conclude that there is a difference between the groups. But if the confidence interval is on that side, we can say that this is effective treatment. If it's on this side, then the control group is better, but we did not design the project to say that the control intervention is better. We designed to say that treatment A is better than treatment B. So we cannot actually conclude that the control intervention is better. Then we had to formulate the question somewhat different. So I will talk a bit more about tomorrow some different trials we have done at Diakonhjemmet. But this was a superiority trial for where we looked at high intensity exercise for 3 months in people with spondyloarthritis. Then it's the non-inferiority. Yeah.
Sorry to interrupt, Teresa, but tomorrow, when discussing the cover trial, David has also prepared to address this non-inferiority.
Yeah.
So you can save time.
Yeah.
And we can address it tomorrow.
Yeah. Yeah. Yeah, but non-inferiority is, in non-pharmacological trials, there is, we often have small effect sizes. So the intervention is not that effective. And this is a way of looking at interventions that may be equally effective but less costly. And I think that was the point with the COBRA trial. Is it a way to do this either more easy for the patient or more cost-effectively? So then we would like to see that it's not worse than the other treatment. But what's important to say here is that if we find that actually the treatment A is better, we cannot conclude with that because this was designed as a non-inferiority trial. So although we find that intervention A is better than B, we cannot conclude with that because then we perhaps would have to have larger sample size. So the way we are designing our trial is really important when it comes to how we can conclude. So this was my example here. Then we have I can't pronounce this word, but this trial. I have not done this kind of trial. I've done superiority, I've done non-inferiority, but not this. And I don't think it's that common. And one reason is I think that you need a really large sample size to be able to prove that something is equal. Because then it should not be either, you have like margins. So you say that an intervention should be within 20%. It should not be bigger difference between the intervention than 15, 20% or something. And then it should be within the margins. So if it's outside, then it's not equivalent. And then you need a large sample size to try to find that. So it's not that common. Yeah. So back to the non-pharmacological interventions. What is the most difficult things, or the things that you should really think about? One is the blinding, because it's difficult, so you have to think about who can you blind. And then perhaps you have to bring in a statistician that can be blinded, if that's at least that. If you can do something more, perfect, but it is difficult. Then it's the control group, and as I mentioned, we often have small effect sizes, so it's difficult to find that one intervention is superior to another, because, like, if we think about physiotherapy, just doing anything is better than doing nothing. And if you're doing aerobic exercise, or if you're training strength training, it's kind of, you get some effect, but it's difficult to tell them apart. So you have to think about what is your control group going to be. And what is also problematic is the ethical part, because you can, or at least in Norway, I think it's the same here, you can take away something that they should get. If this is the guidelines, then we can't take that away. We often use the waiting lists for a control group, because then there might be a period where they're not doing anything. It's difficult to find a control group without that's not doing anything. And then it's the intervention. That's all often very complex, because you have people delivering the intervention, so it makes it harder to say that, okay, it was just exercising. Perhaps it was a really enthusiastic physiotherapist giving the exercise, and if we take away that physiotherapist and saying that do this exercise by yourself, the results may be worse. So we will not find the same results in a different setting, and that's also very very important to think about. So for this trial, we did that with physiotherapists in private or in primary care, and that is because it has shown that high intensity training is good. It's good for almost everybody, but it's often done in a specialist healthcare setting, and that's not where they're supposed to train. So can we do it in another setting? And the best would be, next step would be, can they do it by themselves? Can we just say that, do it, and then will we get the same results as we have done here?
Teresa,
Yeah.
it also relates with having only one provider
Yeah.
versus
Yes.
more in the same center.
Yeah.
Can you explain?
Yeah, because as I said, it's much depending on who is giving it. So here we had 4, just to get a variation, because if it's only one, this person may have a lot of impact and doing it in one way. So we taught them how should you do this exercising, and then patients are they're not randomized because they could choose the one living closest to them. Yeah, if you are to generalize your results, then you should have more than one, because else the generalizability of your results will be bad. Okay, and this was also mentioned, extensions. There are a lot of extensions. There are a lot of so look into the extensions. There is one on the non-pharmacological interventions, and it's mentioning something about this with blinding, who should be blinded, and so on. There are some other things, I can't remember them just now, but look into the extensions that fits your trial. Then another design, which is the crossover design. So this is a design where one patient gets both interventions. So different from the other one, where we only get one. Here the person gets both. And when it comes to non-pharmacological trials, it's again a bit problematic. This design is a bit difficult. And now I'm talking as a physiotherapist, doing exercise trials, because you can't go here in the washout period and say that now you are trained, now stop training. No training for 3 months. That's not ethical. And if they have realized that exercising is quite good, then they won't stop. So there are not a lot of trials that we have not done a lot of these kind of designs because it's not feasible to do them. It's difficult. But it's a design that will demand a smaller sample size, because the person is his or her control as well. So you don't have to have that many participants. But I think that I would be better off having more participants and doing a parallel design, because this is difficult. Another is a factorial design. And this is also a way of doing actually 2 trials in one trial. And you can be off with a bit less sample size, a bit smaller sample size than if you did 2 trials. So then you have a control group, you have a treatment A group, you have treatment B group, and then you have a treatment A plus B. But this design, it actually, there can't be an, oh, I forgot the word, interaction between these 2 treatments. Because when you put them, when you analyzing your data, I can show it here. So you have the no treatment group, you have treatment A and treatment B and treatment A plus B. So when you analyze your results, then you analyze treatment B and treatments A plus B. That's one group, and you analyze them towards no treatment and treatment A. And then you do this for the other. So there can't be any interaction between the 2 treatments that you are comparing. But if you think that the randomized control trial is difficult, then stay away from this, because it's really difficult to do such a trial. But here is a trial that was done. This is hand osteoarthritis. So they get just all the groups got information, and one group got joint protection or orthosis, and the other got hand exercises, and then there was the combination of joint protection and hand exercises. But there are other designs as well, but please start with the most simple one if you're planning a randomized controlled trial. But there might be, I heard something about educational studies, So it's quite difficult if you have a class, then okay, you will do this, but you will do that, and you talk together, and then we will have contamination of the intervention. So perhaps you need to have the whole class. So you are a cluster, you do this, and then you have another class, they do this. So a cluster randomized control trial is possible to conduct if the intervention should be given in a group, or if it's really difficult to do intervention just for some people and not the others. So it's quite that can also be if I was were the physiotherapist giving intervention, and I know that this is really good intervention, and I won't be giving it to you, and then I will give you a bit of the intervention, but you're in the control group. But it's difficult. So if it's really difficult, this is a good design, but it's more demanding and it's more difficult analytically to analyze the results. And this is terrible, but I am working now a lot with digital technology and remote care, which is now coming due to the pandemic. It's really coming fast. And then it's impossible to do a study on something that how we did it before, because it's already implemented. But if you kind of manage to do a trial just when you're implementing something, then this could be a design that you could use. And the thing you do here is that you have different clusters, and then you randomize when they will start to give the intervention in a different way. So in the start, they are all the controls. They give the intervention like they did before, and then they will, in a randomized order, start to give it in another way. So we have a no, wrong way. I will mention a trial tomorrow where we did this, but also this is really difficult when you are going to analyze your data because there is a time issue here as well. I know that I'm running out of time. I was to say something about adaptive designs as well. I have not done that not much of that, because our statisticians say that, oh, don't do that. So then I don't do it. But this is a way of trying to manage the research waste. So if we can find out that either we need a larger sample or we don't need that large sample, this is not effective at all, just stop the trial, or this is harmful. So if this is a way of doing things or adapting this trial when it's ongoing. But all the adaptations should be planned ahead. You're not just supposed to, okay, I will analyze a bit and then, I do some changes. You all have to plan really good, and I think it's difficult just to plan a simple parallel design RCT. So to be able to think ahead of everything that you should do if you're going to make some changes, how you're going to do it, it's quite difficult. But it's a way of not wasting our research. And the last thing, this is possible pre-planned changes that you can do. But the last thing I wanted to say is that one way of avoiding this research waste is to do something first. I think it was really nice that you said that first I do a systematic review, then I do a qualitative study, because we have to know if this is something that we should go ahead with. And feasibility studies and pilot studies is a way, because they're smaller, we can get a kind of idea if this is something that we should go ahead with in just a small sample before we start a big resource demanding clinical trial and end up with, this was bad or no effect, or we could have stopped it a bit before. So I really recommend doing something before you start a large clinical trial. So, I was over time. Sorry.